and we are live today, and I'm going to be teaching on the topic steroid prescription, steroid dispensing in ophthalmology. So it's going to be an interesting topic. We are going to be looking at several things, and I'm going to be trying as much as possible to be simplifying them and making sure that everyone is carried along in this discourse. So weekly we are going to be looking at the introduction, the mechanism of action, classification, indications, contraindications, dispensing tips, and side effects, ocular side effects, and then a conclusion. So quickly, corticosteroids are also known, corticosteroids are also known as steroids and are naturally found in the adrenal cortex of vertebrates, such as cortisol and aldosterone. So steroids are naturally produced in the body of vertebrates. They are naturally occurring, but yet scientists have found a way to produce them in the lab. So there are two main classes of corticosteroids. The first are called glucocorticoids, and the second are called mineralocorticoids. The first is glucocorticoids, and the second is mineralocorticoids. So glucocorticoid is a blend of words. It means glucose, cortex, and steroid. So that is, it is regulating the metabolism of glucose, and it is being synthesized in the cortex, and it has a steroidal structure. So that is why it is called glucocorticoids. And again, every time these glucocorticoids are deregulated, the effects are usually severe. So this is why doctors are careful in dispensing steroids, because you need to understand what it's all about and before you dispense. Now, mineralocorticoids control the balance between salt and water, with aldosterone being the natural form. So they help to control the balance of salts such as potassium and sodium and water in the body. And again, a dysregulation of this hormone can lead to kidney and cardiovascular diseases. So this is why steroids, like I've said before, are very you have to be careful in dispensing them. Other forms of steroids occurring naturally in the body are testosterone, estrogen, progesterone, and vitamin D. Yes, vitamin D is a steroid. So, like I said earlier, that steroids can occur naturally in the body, and they can also be synthesized in the laboratory. Some of the examples of synthesized steroids are prednisolone, hydrocortisone, prednisone, dexamethasone, cortisone, beclomethasone, betamethasone, budesonide, and methylprednisolone. So these are examples of synthesized steroids. And again, examples of synthesized mineralocorticoids are fludrocortisone, 11-deoxycortisosterone, and desoxycortisosterone acetate is an example of synthesized mineralocorticoids. Now, cholesterol is essential in the synthesis of steroid hormone. So this is why in our optometry practice, every time we see a buildup of cholesterol in the limbus, for people who are below 50 years, called acus juvenalis, we want to send them for a lipid profile test, because cholesterol has a way of, it has a link with the glucose in the body. So high level of cholesterol can lead to glucocorticoid resistance, resulting to higher dose of glucocorticoids in order to achieve same effects. So when there's a high level of cholesterol in the body, you might need to be giving a higher dose of steroids to achieve the same effect you would have achieved when there were no when the steroid level, the cholesterol level was normal. Also, prednisolone has been seen to raise low density lipoprotein, that is the LDL. Prednisolone can also cause it to be elevated. So the classification of steroids are this. Classification is based on this classification I'm giving now is based on their acting process. So we have short acting, intermediate, and long acting. Examples of short acting are hydrocortisone. Intermediate acting is prednisolone, methylprednisolone. triamcinolone, deflazacort, and long-acting are dexamethasone and betamethasone. Now, what is the mechanism of action of steroids? There are two basic mechanisms of action. The first is the genomic and the second is the non-genomic. The summary of it all is this. In the genomic, the hormone binds with an intracellular receptor which, when it enters the nucleus, influences gene expression. So in genomic, the hormone enters the cell, binds with the receptor in order to change the workings of the gene. And this process is usually slow acting. But then in the non-genomic, the cellular action usually happens rapidly and independent of the gene transcription, and it occurs within seconds or minutes. So it doesn't necessarily need to change the gene transcription in order to take action. So now, what are the indications for steroids in ophthalmology? When do we give steroids? And I must say this before I continue, that just in case you are not sure of giving steroids, it is better you do not give than to be doing a guesswork and then give steroid for the wrong person. So what are the indications for steroid? The first is uveitis. Of course, whenever there is inflammation, steroids are your best go-to, but then you must be careful. So uveitis is one of the indications for steroid. Post-operative inflammation, after a patient does cataract surgery, we usually give them steroids in order to quieten any inflammation that can go on during after the surgery. Also, allergic disorders such as atopic and venous keratoconjunctivitis are cases whereby you can give steroid eye drops. Also, severe dry eyes. There are cases of severe dry eyes whereby topical steroids are also given. Also, when there is a graft rejection, when for instance, a patient who does cornea grafting, we usually want to give steroids because steroids also have immunosuppressive abilities. They also have immunosuppressive abilities. Also, in cases of swelling, pain, and redness, it is an indication for steroids. Also, in thyroid eye diseases, is also another indication for steroid. Giant cell arthritis is also another indication for steroid. Now, what are the contraindications for steroid? Where are the cases we see and we don't want to give steroid? The first is glaucoma. So in cases of glaucoma, we are careful not to give steroid because, like we all know, steroid can increase the intraocular pressure. So in glaucoma, please make sure you are not giving steroid. But if you must give, you must make sure that you balance it. Again, in cases of ocular hypertension, in cases where a patient has a history of ocular hypertension, please be careful in giving steroids. Also, narrow anterior chamber. If the anterior chamber is narrow, you know steroids also increase intraocular pressure, and the anterior chamber is narrow, which means intraocular fluid cannot flow out, which will build up pressure and cause a lot of damage. Also, when there is an active herpes simplex keratitis, so it is, and again, every time you see an undiagnosed red eye, please do not be quick to give steroid. You must only give steroid when the red eye has been fully diagnosed, because conjunctivitis can lead to red eyes, keratitis can cause red eyes, viral infection can cause red eyes. So please make sure you have diagnosed the red eye effectively before giving steroids. It's not something you just give and say, oh, your eyes are red, take steroids. No. Also, fungal eye infections, steroids are contraindicated. Corneal ulcer, steroids is a daisy matter in giving steroid for corneal ulcer. Also, when there's a recent vaccination, please do not give steroids, systemic steroid, when a patient has just done a recent vaccination. Why? Because steroids can, this is to avoid immunosuppression, because steroids can suppress the immune system, and you don't want to suppress the immune system when a patient just took vaccination. Also, in cases of peptic ulcer, please do not give steroid unless the peptic ulcer is under treatment. Now, let's go to the dispensing, and we'll call it a day for today. So, what are the dispensing tips we need to know? For children, that is pediatrics, we must be careful because steroids can lead to can lead to reduction in growth in children. Steroid can cause retarded growth in children. So we must be careful when giving steroids to children. And also the weight and growth should be measured regularly. The weight of the child must be noted before giving steroid. And the formula is this: 1 millimeter to 2 millimeter per kilogram of body weight divided and taken 3 to 4 times a day, depending on the condition for children. 1 millimeter to 2 millimeter per kilogram of the body weight divided and taken 3 to 4 times daily, depending on the condition for children. So which means before you dispense steroid for a child, the weight must be measured. Now for adults, we give from 5 to 60 milligrams per day for adults when we are giving steroids. Now how do you know the dosage to give? Now, in cases where you see a condition, maybe for instance, uveitis, how do you know if I'm going to be giving 5 milligram, or I'm going to be giving 20 milligram, or I'm going to be giving 60 milligram? Because the range is 5 to 60 milligram. Now, how do we know the range to give? Now, this is my own research and my own way of practice. Now, this is how I do mine. For mild cases, I give 20 to 30 milligram per day, maximum of 30 milligram per day for mild cases. So if I'm giving 20 milligram for instance, I can decide to give 5 milligram in the morning, 5 milligram in the afternoon, 5 milligram in the evening, 5 milligram in the night. So I spread the 20 milligram per day. If I'm giving 30 milligram, I spread it per day for mild cases. Now, what if it is a severe case? I want to give about 30 to 40 milligram per day for moderate cases. 30 to 40 milligram per day. Then for severe cases, I want to give 40 to 60 milligram per day, and it is being spread for that day. So for instance, upon your slit lamp examination, and then you are looking at the anterior chamber and you just see little flares in the anterior chamber, now you are grading it as a mild case. Few flares, few cells there, few keratic precipitates. You know this is a mild case. You are giving about 20 to 30 milligram per day. Now, assuming I look again at the anterior chamber and then I see a lot of flares, but they are not so much all over the anterior chamber, and I know this is not a mild case and it's not a severe case, so which means it is a moderate case. In this case, I want to give about 30 to 40 milligram, depending on what I'm seeing. Then for severe cases, I'm seeing a lot of keratic precipitates, inflammation, synechia. I'm seeing flares here and there. This is a severe case. In fact, you know, it's a classical case of uveitis. I want to be giving about 40 to 60 milligram per day. Now, for geriatrics, we must note certain things because we want to rule out kidney issues for geriatric patients. Please, before you give them steroid, rule out kidney issues, rule out bone issues, because a steroid can also cause the bones to begin to break more than they break abnormally. So it is important you rule out kidney issues, rule out bone issues for geriatric patients. And also for breastfeeding mothers, there is no contraindication. You can give steroid to breastfeeding mothers, but then our advice, give the minimum dose as possible for breastfeeding mothers. Give the minimum dose you are sure that this dose will do the work without overstepping your boundary. That is for breastfeeding mothers. So finally, let me go to the tips. What are the basic tips you should know in dispensing steroids? 1, ensure patient is under antimicrobial treatment in cases of systemic infection. Please, before you give steroid, make sure that the case you are handling is not a systemic case that can be handled with antimicrobial infections. Rule that out. Now, 5 milligram of prednisolone has the same effect as 20 milligram of hydrocortisone. And again, 5 milligram of prednisolone has the same effect as 0.7 milligram of dexamethasone. Now, another thing, most doctors are afraid of giving steroids. Now, before you give steroids, I advise that you should be sure that this case, steroid is my last resort. If there are other drugs that can do the work, I advise you don't go for steroids. If NSAIDs can do the work, that is non-steroidal anti-inflammatory drugs can do the work of what you are saying, please advise go for NSAIDs. But just in case you've weighed the options and from your clinical insight you are saying that okay, for this case steroid is the best fit, this is what you have to do: hit as hard as possible and quickly. Most times doctors are afraid of giving steroids, so most times they give a lower dose which does not have a maximum effect. So once you are sure it is steroid, for instance you are sure it is a severe case, give the highest dose as possible, as said earlier. Hit hard as possible and hit quickly. Now, do not taper until inflammation is controlled. A lot of people, they begin to taper even when you are still seeing the flares, you are still seeing the precipitates, you are still seeing the inflammation. Do not taper. You taper when the inflammation has been under control. Are we together? So do not just say, okay, give for 2 weeks and begin to taper. No, keep giving that dose until you see that there's an improvement, a significant improvement. Then you can begin to taper the steroids. And again, if you are giving steroid, you must monitor closely for side effects. For instance, if I'm going to give a steroidal eye drop or an oral steroid, I will also, if I'm giving a steroidal eye drop, a topical steroid, I will also want to attach it to an eye drop that can also, that is anti-hypertensive. For instance, if I'm giving a steroid eye drop, I will also be giving a drug like timolol or brimonidine or latanoprost. This is to counter the case of increased intraocular pressure, because we all know that steroids can increase pressure. So if you are giving topical steroids, please ensure that you give drugs that can also lower eye pressure simultaneously. So like I said before, do not taper until inflammation is controlled. Systemic steroids are not for long-term use. You should know this. So for instance, if you should give, assuming you are giving 40 milligram, and then if you are going to give 40 milligram and you want to begin to taper after 2 weeks,